All right, let's talk about a condition that's gone from being this obscure thing you'd only find in old medical textbooks to something that's now at the very forefront of cardiology. This is cardiac amyloidosis. And really, it's an incredible story about medical detective work, deep molecular science, and a treatment revolution that's giving so many people new hope. So let's dive right in.
So picture this. For the longest time, doctors were kind of stumped. They'd see patients with all the signs of heart failure, but when they looked at the heart, it wasn't weak like you'd expect. Instead, it was thick, rigid. They called it stiff heart syndrome, which was a great description of the problem, but it didn't tell them why it was happening.
Well, the answer to that mystery is cardiac amyloidosis. At its very core, this is a disease where proteins go wrong. Just imagine these tiny, misfolded proteins acting like insoluble gunk, building up in the spaces between your heart cells. And all that buildup is what makes the heart muscles so stiff and keeps it from relaxing and filling up with blood like it's supposed to. So here's what we're going to cover. First, we'll get into the nitty-gritty of this protein problem. Then, we'll unravel this tale of two very different diseases that hide under one name. We'll learn how to spot the crucial red flags, walk through how doctors diagnose it today, and then get to the best part, this new era of treatment that has changed absolutely everything. Okay, so let's start at the very beginning, at the molecular level. We're talking about a fundamental failure of how proteins are supposed to fold. You know, these amyloid fibrils, this gunk, it's not just sitting there. It's actively messing things up, physically getting in the way of the heart's machinery. As it piles up the heart's main pumping chambers, the ventricles, they lose their ability to stretch. This creates what doctors call restrictive physiology. Basically, the heart becomes so stiff it just can't relax to fill with blood, which causes a huge traffic jam of pressure, and that leads straight to heart failure. Now, this is where things get really interesting. Get this. Even though there are over 30 different proteins that can misfold and cause amyloidosis, more than 95% of all cardiac cases come down to just two culprits. And honestly, understanding the difference between these two is the single most important thing in managing this disease. First up, we have AL amyloidosis. The best way to think about this one is as a blood-related problem. It's caused by rogue plasma cells, usually in the bone marrow, that are just churning out these bad, unstable proteins called light chains. This form is a flat-out medical emergency. Why? Because those light chains aren't just building up, they're directly toxic to the heart cells, causing damage incredibly fast. So the goal is urgent. You have to shut down that factory making the poison. And then we have culprit number 2, ATTR amyloidosis. This involves a totally different protein, called transthyretin, or TTR for short. Normally, TTR floats around in your blood in this nice, stable 4-part structure, kind of like a 4-leaf clover. But in ATTR, that clover becomes unstable and breaks apart. Once those individual pieces are loose, they misfold and start clumping together in the heart. This can happen because of a genetic mutation you inherit, or, for many people, it just happens as part of the aging process. And you can see right here just how different these two really are. It's like night and day. ALL is a wildfire, progressing over months, while ATTR is more of a slow burn, taking years. ALL tends to hit lots of organs, the heart, the kidneys, the liver, while ATTR really likes to target the heart, nerves, and soft tissues. And here's the bottom line, you absolutely cannot treat them the same way. Figuring out which type of patient has isn't just an academic exercise. It is, quite literally, a matter of life and death. So, if it's so critical to catch this, how do we do it? Well, one of the biggest problems with amyloidosis is that it's a master of disguise. The key to unmasking it early is to look for clues that, believe it or not, often show up years before the heart even starts to complain. Now, take a look at these. Notice anything? None of them are your typical heart symptoms. For so many patients with ATTR, their medical journey doesn't start in a cardiologist's office. It starts with an orthopedic surgeon. Years before they feel short of breath, they might have had surgery on both wrists for carpal tunnel syndrome or developed serious back problems from spinal stenosis. This whole orthopedic to cardiology path is a huge, huge window of opportunity for us to find this disease early. And this quote just says it all, doesn't it? The disease is leaving breadcrumbs in the ligaments and tendons long before it ever overwhelms the heart. And that is why it is so critical for orthopedic surgeons, neurosurgeons, and primary care doctors to be aware of this. Now, AL amyloidosis has its own unique and frankly kind of strange calling cards. They're not super common, but if you see them, you have to think about AL.
We're talking about things like a visibly enlarged tongue or getting bruises around the eyes for no reason at all, what doctors call raccoon eyes. If you see those signs, the alarm bells for AL should be ringing loud and clear. Okay, so let's say a doctor has a hunch. They've seen some of these red flags, and they're starting to think, could this be amyloidosis? How do they actually get to a definitive answer? Well, the great news is we now have a very clear, step-by-step process that takes us from suspicion all the way to certainty. And here is the single most important rule in the entire diagnostic playbook. It is the AL first imperative. Before you do any fancy imaging, before anything else, you have to run simple blood and urine tests to look for those bad proteins that cause AL amyloidosis. This is completely non-negotiable. Why? Because AL is a medical emergency. And if it's positive, that patient needs to see a hematologist like yesterday. So the path is really logical when you lay it out. It all starts with that clinical suspicion, seeing the red flags. Step 2 is that absolutely crucial AL screen. If that comes back negative, then you move on to advanced imaging. And the final step is locking in the diagnosis and being 100% sure of the exact subtype.
And this right here, this is the real game changer in diagnostics. It's a nuclear medicine scan called a PYP scan. It uses a special tracer that just so happens to stick directly to ATTR amyloid deposits in the heart. So if that initial AL screen is negative and this PYP scan lights up like a Christmas tree, what we call a grade 2 or 3, then congratulations, you have your diagnosis of ATTR cardiac amyloidosis. And the best part? For most patients, this means we can completely avoid a risky, invasive heart biopsy. And all of this leads us to the most hopeful, most exciting part of this entire story, the therapeutic revolution. I mean, for decades, this was basically a hopeless diagnosis. And now, today, it's a treatable condition. And just like the diseases are totally different, the treatment strategies are worlds apart. For AL, you're targeting the source, the bone marrow. The goal is to wipe out those rogue plasma cells with chemotherapy to stop the production of those toxic light chains. But for ATTR, the goal is totally different. It's all about stopping the TTR protein from breaking apart and misfolding in the first place. And for ATTR, we now have 2 incredible strategies. First, you have TTR stabilizers. You can think of these like a molecular superglue that binds to that 4-leaf clover structure and just holds it together, preventing it from breaking. Then you have TTR silencers, which take a completely different approach. They go to the liver, where TTR is made, and they basically silence the gene responsible for making it. They cut off the fuel supply for the disease. And this isn't just theory, we have powerful, real-world data. The landmark clinical trial for the first TTR stabilizer, a drug called tafamidis, showed a 30% reduction in deaths from any cause and a 32% reduction in hospitalizations. This was a watershed moment. It was the first time any drug had ever been proven to change the natural history of this disease, and it kicked off this new age of hope. So all of this brings us to where we are today. The entire perception of cardiac amyloidosis, what we thought it was, has been completely turned on its head in just the last few years. We are truly at this amazing inflection point. On one side, we have things like artificial intelligence that can scan routine heart tests and automatically flag patients who might have this disease, helping us solve the detection problem. And on the other side, we have this growing arsenal of amazing therapies that work best when you start them early. This combination is turning what used to be a rapidly fatal disease into a manageable, chronic condition. And really, the crucial point is this. We now have the tools to find this disease without surgery, and we have treatments that can fundamentally change its course for the better. The science has delivered. So that leaves us with one final big question. With all these life-altering treatments now available, is the biggest barrier left to saving lives simply making sure that every single doctor and every patient knows to look for it? Thanks so much for joining us.